Okay, so now we are set. My warm welcome to you, 216th welcome. Today we'll be talking about neuropsychological rehabilitation in SMIs. Uh, Very important topic, less heard of, and we have a speaker who will try to give us practical tips how to do that. And we have two very learned speakers who are the uh, leading lights of this field, I can say. So this meeting is now being recorded. It will be posted on the YouTube for future viewing. The host has muted everyone. You can ask the questions in the chat box, which will be taken up to the speaker. So now I'm handing over the session to Professor Dr. Sofan Pati sir. He is the chairman of this program. Sir, over to you.
Thank you, Dr. Ali. We have a very interesting topic, often ignored, but it is very important. Everyone understands it. Nobody can deny that. And I have the formal duty to introduce. I shall just state the names of our vibrant moderators. Please, Dr. Vishal Chabra, Dr. Alim Siddiqui, Dr. Amrit Patudosi, and Dr. Shobit Kaur. And claps for all of them. Our chairperson is one Dr. R. Thara, who is the co-founder and vice chairman of SCAR. He is an advisor panel to DZ, WHO Geneva. Passionate about disability, instrumental in including mental disability and developing ideas, the scale to assess disability. Involved in many national and international research projects. Over 200 publications on editorial board of many international journals. Many awards, including outstanding research in clinical social psychiatry from Schizophrenia Intelligent Research Society, the Nari Shakti Puraskar from President of India in 2022. Welcome, Dr. Thara.
Thank you, Dr.
Dr. P.S.V.N. Sarma from Manipur. He is currently professor and unit head of Department of Psychiatry, KIMS, Manipur. Was HOD of the same department from 1993 to 2018. Envisioned and built state-of-the-art rehab center in KMC, Manipur, Mumbelaku. Welcome, Dr. Sarma. It is very highly rewarding to have you here. We look forward to your inputs. I'll request one of the chairperson to introduce Dr. Jyoti Misra and the other chairperson to introduce the topic. Yes. Dr. Thara will introduce and will introduce the topic that you can decide. Dr. Sharma.
Dr. Sharma, do you like to go?
Yes, Dr. Sharma would like to introduce Dr. Jyoti Misra.
So, Dr. Jyoti Misra is a MSc, MPhil, and PhD and an assistant professor of clinical psychology at the Department of Psychiatry in the Government Medical College.
Your audibility is feeble, sir. Can you?
Okay. Can you hear me now, sir?
Yes, sir.
Dr. Jyoti Misra is PhD and assistant professor of clinical psychology at the Department of Psychiatry in the GMCH Chandigarh. She did her MPhil from CIP Ranchi and PhD from the Ranchi Institute of Neuropsychiatry and Allied Sciences of Renpas, Ranchi. The rank holder in her MPhil clinical psychology, professional member of the Indian Association of Clinical Psychology, and more than 10 years of teaching experience, more than 8 years in the field of psychosocial rehabilitation in severe mental illness. There are more than 30 research articles and chapters in internationally indexed books like Springer, Sage, Elsevier, co-authored a book on behavioral interventions in pervasive developmental disorders in 2020, received the S.C. Gupta Award at the 46th National Conference of the Indian Association of Clinical Psychology, co-authored manual of performance tests of intelligence edited by Dr. Naraka Prasad, board member of the Parental Guideline Project under the Indian Academy of Pediatrics, Action Plan 2021, and contributed in preparing parental guidelines on the care of child with intellectual disability. She is a co-investigator in the Department of Science and Technology funded research project entitled Brain Exercises for Better Cognitive Functioning in MCI and Dementia in collaboration with the Department of Neurology in Pediatrics and Chandigarh. Former faculty of CIP Ranchi. The area of expertise obviously is neuropsychology and SMI rehabilitation. Presently working on manual-based cognitive retraining module of SMI as a principal investigator in the GMCH Chandigarh.
Thank you, sir. Thank you so much. If Thara ma'am can introduce if both of you can speak a few words about the topic before we start.
Yeah, I mean, rehabilitation, as somebody already said, has always received stepmotherly or stepchild kind of treatment, in academic psychiatry. There are many reasons for that. It is very difficult to say why this has been so. But rehabilitation has no shortcuts. I mean, it's not an easy thing to do. Maybe that is one of the reasons why people don't want to take it up and don't want to talk about it either. So I'm very glad that, indeed, I'm very glad that you have chosen rehabilitation as a subject. And I still remember Dr. Sharda Menon, who founded SCARF, used to say that rehabilitation should start on the very day you diagnose a patient. You should not wait for 2 weeks or 1 month or 3 months. So that is a kind of mindset all of us must have when we talk about rehabilitation. And I'm sure we are going to hear from my young colleague. They say Thursday, just now my artificial intelligence on my phone said Thursday is a day of thunder. So let us hear some thunder from Dr. Jyoti now. And over to my very esteemed colleague, Dr. Sharma.
Thank you, ma'am. You're talking about thunder. There is actually thunder and lightning here in Manipal.
Okay.
That apart, yeah, like the Tara was saying, actually, if you look at the history of psychological rehabilitation, it all started in the First and Second World War with brain trauma, brain injured people, and trying to restore functions. So that's when cognitive rehabilitation took off. And at that time itself, in the 1940s itself, along with cognitive rehabilitation, people even talked about affective domain, social domain, functional domains, and so on. It's somebody called Oliver Zangwill who for the first time talked about compensation, substitution, and direct training. And that remains with us as a bedrock even now. And that's something that we need to remember. Neuropsych rehab in psychiatric practices, obviously, I think dates back to the 1990s, really, when people started taking interest in it. And we have moved forward. I'm sure Dr. Jyoti will be telling us a lot about the origins and the basis and the current status and how we can probably implement it in our day-to-day work. Thank you very much. Jyoti, over.
Thank you so much, sir and ma'am, for this kind word in introduction of mine. And thank you, the organizing team, especially Alim sir, for having me here on this. And I have to speak on a very pertinent topic, neuropsychological rehabilitation in SMI. Can I share my slides, sir, now? Can I start sharing?
Yes, please do. Please start.
Yes, sir. So is it visible?
Yes.
So it is a very important topic, especially when it comes to its efficacy in SMI, because I can understand the skepticism it has about its efficacy. Especially, it seems very challenging when it comes to measuring its impact at first. But considering this severe mental illness and chronicity of the illness and how it is impacting the human life, it may not be a quick fix. This cognitive retraining may not be a quick fix, but it is an evidence-based practice if it is done properly. The treatment of SMI, when you see, is my screen moving?
No.
Oh, first slide. You're on the first slide.
Yes. So if you see the evolutionary movement in treating severe mental illness, it has started from custodial care to treatment-based approach to right-based approach. Now, the important component in right-based approach is the right to live in community. So there's a significant change when it comes to treating the psychiatric illness, especially the chronic psychiatric illness. Parallelly, in the field of medicine, there was some evolutionary movement in terms of treating psychiatric illnesses, introduction to antipsychotics. So when antipsychotic medicine came into picture, introduced, it was a game changer in terms of treating psychiatric illness. But the efforts of the fellow mental health professionals was not up to what was anticipated. They anticipated the outcome beyond the treatment. It was mainly the community integration. So there it came the difference between the remission and recovery. So remission is just treating the condition, but recovery is beyond that. It mainly includes the full participation in society, work, and independent living. And what hampers these component, one of the major component of like hampering these areas is the cognition. So if you see the path between the remission and recovery, which rightly said, it starts from the remission at the day of, patient enters to you or being diagnosed. So the important component in terms of this road to recovery is the cognition. So it impacts the overall functioning, overall prognosis of the condition. So if you see the cognition, it is a diverse ability that allows an individual to recognize, process, and respond to given information. So if you see the DSM-5 cognitive domain, the following classified components of cognitions are learning and memory, attention, concentration, executive functions, language, perceptual motor, and mainly the social cognition. So when you talk about the cognitive function and neuropsychological evaluation and assessment, this is the area, social cognition, which we normally missed it. And it is very pertinent when it comes to schizophrenia and other chronic illnesses. So considering cognition in severe mental illnesses, I broadly covered schizophrenia, mood disorder, major depressive disorder, and OCD in it. So it is associated with persistent symptoms, cognitive impairment, and long-term disability. So unlike any other neurological condition, neuropsychiatric illnesses they are heavily influenced by the social environment, and numerous studies have demonstrated a strong association between severity of cognitive impairment and the functional and social outcome in schizophrenia and bipolar disorder. So the vocational outcome are poor in people with SMI, with many experiencing long-term unemployment and welfare dependence, despite evidence that they could gain a considerable benefits from engagement in paid employment. So cognitive impairment is an important determinant for poor engagement with vocational rehabilitation services and failure to maintain a job tenure. So researches into measures to improve cognition is therefore driven by the hope that such improvement may lead to better long-term outcome and greater opportunity for social inclusion. So if it's the cognition in SMI population, be it schizophrenia, be it bipolar disorder, major depressive disorder, or OCD, it involves executive functions, language, social cognition, attention and processing of speed, and different areas of the brain, mainly the prefrontal cortex, along with the limbic system and amygdala. I'll be very brief in terms of introduction because I have to talk a lot on the rehabilitation part. So the cognitive intervention in severe mental illness, the effect of severe mental illness has shown, like in multiple meta-analysis and systematic analysis, this efficacy has been proven that it is effective in terms of better outcome in SMI. However, there is no consistent evidences that such improvement we can generalize to better functioning in real life situations. So there comes the question on generalizability of neurocognitive outcomes. So it's more about neuropsychological interventions efficacy in SMI if we consider lot of meta-analysis, lot of systematic reviews indicating that moderate to large effect size of cognitive retraining on memory and executive function, but low on cognitive life, quality of life. So if we see the outcome in the work area, yes, it showed it shows improvement and increase in quality of work life, but in a supported employment, not in an independent employment when it comes to this illness. And another study, the effect of rehabilitation and combined approaches, rehabilitation and psychosocial rehabilitation. The outcome is there, but it is very suboptimal. Cognitive impairment have severe implications for functioning and might reduce the effect of psychosocial rehabilitation. If you see this chart of various research articles, very nicely they have mentioned the efficacy, the effect size of global cognition, cognitive stimulation on global cognition. So these are the studies where you can see a good effect size, a large effect size. When the common factor among these articles, these studies are the long hours of intervention. So it is not the intervention, it is the how many hours you are giving for stimulating the brain and doing the cognitive retraining. And if you see the outcome of these researches, all these 4 articles which I have identified, the improvement was significant in terms of functionality, but it was combined with other form of rehabilitation and been included with strategic coaching. I'll come to the techniques that we use when we talk about rehabilitation. So what challenges this condition, this neuropsychiatric condition poses on cognitive retraining, despite knowing the evidence, despite knowing the efficacy, why there is inconsistency in terms of its outcome. So we should not ignore the fact that we are dealing with an impaired learning machinery. So now take the example of a person, a roadside accident or TBI or acquired brain injury. What happens to that? And what we expect that after an injury, within 3 months to 6 months period of spontaneous recovery. So what is that spontaneous recovery? Because the brain has a natural tendency to recover. Can we expect the same from a severe mental illness? Because when the patient become asymptomatic, we expect that the cognitive impairment recovery will be there in cognitive impairment and other functionality. It is not like the same. So we are dealing with a poor networked learner, heavily influenced by social cultural factors, childhood experiences, family trauma, and everything. So from this background, from efficacy of cognitive retraining in literature, the take-home message would be that in CR, not the intervention, but the hours of intervention matters. Secondly, the literature says that the long hours of remediation has high impact effect size in comparison to fewer hours of remediation. The outcome was better when it was augmented by psychosocial rehabilitation and vocational rehabilitation, psychosocial rehabilitation, and not a standalone trial, be it your psychosocial rehabilitation or CR intervention. A combined approach required to have a better outcome and large effect size. So be it 1800 study or 2023 studies, the CR cognitive retraining has never put us down in proving its efficacy. Always remember what you are dealing with and associated obstacles that SMI carries. The kind of behavioral intervention that can work well for a healthy brain may not yield the desired outcome when we are applying to a developmentally and plasticity impaired brain. So why neurology in the era of brain imaging? We all are aware that brain imaging is limited in terms of stating and showing the functional outcome in the real world. There, the role of neuropsychological assessment and management comes into picture. But I am in favor of this imaging because this functional imaging, neuroimaging, helps us to visualize the outcomes, visualize the associated various perspective, cognitive and emotional outcomes. So neuroimaging can be recorded before, during and after the rehabilitation to get a very clear-cut picture of whether the improvement has occurred and if it occurred on what level, on what structural and chemical level. So what happens to the brain? There the concept of neuroplasticity occur, we all are aware of. So the neuroplasticity, the basic question that comes when it comes to the, till how long the brain will develop, the plasticity will occur. The very common questions. So the answer it depends upon the critical window of that age. So if you see the developmental critical window, it is initial 5 years is very crucial for neuroplasticity for these children. After this, neuroplasticity occurs up to 45 or 40 years of age. After that, it still persists, but it slows down. So as per the literature, the neuroplasticity occur until you die. So we should never lose our hope in terms of stimulating our brain. So brain has the inherent capacity for change in order to promote or restore adaptive, cognitive, and socio-adaptive processes. SMI can be broadly viewed as these, biased distributed neural representation, and this brain exercises can do wonder, or can do some or little changes in this field. So if you see the study, the neuroplastic finding, you can see the changes after the cognitive retraining and social cognitive retraining. Significant reduction in the gray matter, reduced gray matters, increased volume in several medial temporal areas after CT, hippocampus, parahippocampus. So there's a number of studies, meta-analysis, and systematic reviews showing the efficacy of cognitive retraining and socio-cognitive retraining in the field of severe mental illness. So the take-home message from this would be that impaired brain is capable of adaptive plastic changes despite its underlying neuropathology. So whether we are dealing with impaired machinery or an intact machinery, it has its efficacy. Now coming to the neuropsychological rehabilitation, I'll take you to the basics of neuropsychological rehabilitation. Why I started talking about neuropsychological rehabilitation later, because I wanted to first put an emphasis upon the efficacy, that there is an evidence-based literature that it is efficacious depending upon the criteria that you are taking, the hours of intervention, and the collaboration with other approaches. So the neuropsychological rehabilitation, apart from cognitive rehabilitation, taps beyond the cognitive retraining. It covers the real life or real world outcomes such as work, socialization, and independent living skills. So the goal is not to cure. Always remember, in SMI, in rehabilitation, our purpose is not to cure the condition, but to achieve the maximum functionality. We have to make the person functional so that they can live fullest in the real life. So the neuropsychology, considering it is of two types. One is the neurocognition and the second is the social cognition. So this neurocognition mainly covers the, we call it cold cognition, the working memory, verbal working memory, speed of processing, executive function, and the visuospatial area. When it comes to social cognition, it is all your interaction, your social functioning, how you are managing the relationship, how you are interpreting the relationship, and how you are surviving in the society. So social cognition plays a significant role when it comes to social life. Both are separate but correlated to each other. So I'll not go in detail about the basic cognition, brain functions of lobe, be it frontal, parietal, temporal, and occipital. We all are aware of it. I'll give a little glimpse of social cognition deficit. It is very important. Social cognition studies how people think about themselves and how they see the world and how they select, interpret, and remember, and how they take the decisions in social situation, interpersonal situation. Mainly it is theory of mind, what others are thinking, why they are thinking, and the attributional bias. Whatever they are thinking, it maybe whatever they are thinking or the others are thinking, how they are attributing it, be it internal attribution, be it external attribution, or the environmental attributions. And the third component is the social cue perception, how we are observing the society, how we are observing picking up the cues from the social situations, non-verbal cues, be it non-verbal or verbal cues. And the four important component is emotional cue perception. It refers broadly to perceiving and using emotional adaptability, and mainly the facial expression, how we are perceiving the facial expression of other people in our surroundings. So there are four components that covers the social cognition. One is the theory of mind, what the other person thinking and why it is thinking, attributional biases, social and emotional cue perception. So if you see this diagram, it mainly covers, it is a social brain network. So it mainly covers the prefrontal cortex, dorsolateral prefrontal cortex, and the inferior frontal gyrus, middle prefrontal cortex, temporal parietal junctions. So it covers broadly like these areas. Like this is called the social brain network. Now see this diagram in terms of understanding how we interpret the social situations. Sometimes we normally say that it is not true what we always see and what we always hear. So we should always keep a check on what we are thinking, what we're interpreting. So considering this social situation, at a social occasion, a friend just finished a phone call and he had a bad news about recent job loss. He didn't tell it to his friends. So now what are the interpretation the fellow person will form? My friend is angry because of the facial expression or the social cue under perception. I don't think that there is a reason to be angry. It is unreasonable. He should have fun. We hardly ever see each other. I think he should not enjoy being out with me. Or internal attributional bias, I can better stay in myself. This is very stressful. So how this misperception of emotion, misperception of social context, and failure to understand the other person's mental state and wrongly attribution. This whole situation creates a problem in social networking, in social, in like consequences of social anxiety, defensive behavior, feeling of anger and resentment. Now, neuropsychological assessment, these are the tools. I'll not go in details about the tool because we all are familiar of the tools. You can use these tools individually also and in a form of battery also. So there is a tool for attention, there's a tool for executive function, there's a tool for learning and memory, language. And if you see the whole tool in battery, the enhanced neuropsychological battery is there, PGI-BBD is there, Bachelor Memory Scale is there, and Luria Nebraska Neuropsychological Battery is there, and the Eames Neuropsychological Battery. And the social cognitive assessment, we have very less tool here, but I have tried to pick up those which we can easily use it, and it is widely used in Indian setup. You can go through these tests. Social cognition, Socrates, Cantab, emotional intelligence scale, and the following. So it assesses in your social intelligence, emotional intelligence, and your perception. Now, the functional assessment in neuropsychological rehabilitation, very important because it is of no use when you are assessing the intelligence. When you are assessing the cognition, neuropsychological cognition, you are introducing the therapy, neuropsychological rehabilitation therapies and social cognition therapies, but we are not assessing the functionality. So if you not assess the functionality, it will be difficult for you to tap where the deficit is occurring in terms of real life situation. So this is a website. This is a, sorry, site. You can go, you can lot all the, I mean, maximum test, be it your stress burden or the ADL, IDL, a good list of tests is given in this article. So you can go through it, and majority of the tests is available in and widely used in Indian setup. And there's another article, assessment tool in psychiatric rehabilitation. You can go through. There they have given a very comprehensive assessment tool, be it cognitive assessment, be it social assessment, intelligence, everything. They have nicely covered it in this article. Now, the functional assessment that I commonly use in my setup is the ICF, International Classification of Functioning, Disability, and Health. Activities of daily living, instrumental activities of daily living, the social occupational functioning scale, quality of life. So these are four scales that help me in understanding how the cognitive impairment or the disability because of psychiatric illness, because of the chronic illness, is impacting the daily functioning. Because then it will help me in planning the therapeutic management. iSave is a very good tool because it actually taps nicely the limitation and the participation restriction domain. This is a tool which covers broadly general task demands, learning and applying knowledge, communication, mobility, self-care, domestic life, and interpersonal relationship. How you can assess it in terms of in these domains, how much independent the patient is and what kind of support system that patient is required in terms of doing these tasks. There is also a qualifier for environmental barriers and a qualifier for environmental facilitator. So it is not like that it only taps the negative part, it also taps the strength of the person, which we can use in terms of planning the rehabilitation of the patient. ADL scale, which normally measures the basic activities of daily living, and then the instrumental activities of daily living. Now, the principles of neuropsychological rehabilitation. There are three principles when it comes to understanding how the neuropsychological rehabilitation work. First is the restoration principle, where we normally work on the deficit brain areas. For example, there is a deficit in the speed of processing. There's a deficit in the executive functions, frontal area, temporal lobe area, or occipital area, or parietal area. So it mainly covers restores the deficit zone. Second is the compensatory zone, where the restoration is not possible. So in that condition, because compensatory techniques doesn't rely on these brain areas. So we create as alternative strategies so that we can make the person more functional. So in compensatory principle, we mainly focuses on prospective memory, attention, learning and memory, and executive function, because these four areas actually requires when it comes to functioning healthily in the real life situation. Now, third is the residual functioning of the brain. So now what happens in this residual functioning? It is mainly a neglected child in a family where if there is two siblings, one is a disabled child and one is a healthy child. We normally ignore the healthy child, stating apne aap kar lega. He is capable of doing it, but it is not like that. We have to stimulate it. It is equally important. So we have to keep on stimulating the healthy area of the brain. So neuropsychological assessment doesn't always tap the deficit area. It also taps the strength of the patient. So keep on stimulating that area also. Because in brain, there is no single territory. This zone, related to the memory part. This zone is related to the occipital part. This zone is related to the frontal part. It is a network. So every area is connected with each other. So the neuropsychological rehabilitation techniques is based on the principle only, the restoration technique, by doing lot of exercises, stimulating the brain. Compensatory techniques, where you think that the restoration is not possible, and we can optimize other strategies from the environment. And third is the residual techniques. I'll go one by one. So how we can restore the impairment. So the approaches normally we follow is the drill and practice approach in neuropsychological rehabilitation. Keep on stimulating the brain. Keep on stimulating by giving the cognitive exercises, be it your planning, execution, or speed of processing tasks. Keep on drill it to the best. Then attach strategic approach, bridging group strategies को हम बोलते हैं. So what happens in this approach, you are drilling it, but you are not correcting it. In first approach, drill and practice approach. But in drill and strategic approach, you are helping the patient in correcting where the patient is committing error. So it is a form of errorless learning, which is a very good approach when it comes to good rehabilitation outcomes. So order may be bottom-up approach and top-down approach. Bottom-up approach is starting from the basic cognitive functioning, your attentional and speed of processing, to the higher cognitive functioning. Top-down approach is the opposite, from top higher executive function to top-down principle. Booster session is recommended. Booster session is recommended for sustaining the outcome. Now, what could be it is just a, I've just given few examples of it, how we can restore the impairment. So area of impairment would be after the assessments, it can maybe speed of processing, attention, executive function, beat set shifting, response inhibition, working memory. So there are software available. With software, you can stimulate the brain by doing exercises. BFT, brain function therapy. You can do the exercises with these software. Cogbrain tab is there. It is not available online. It is created by our own a person from engineering department of Punjab University. So it is a very good software, and we normally use in our daily practice. So another is the Brain HQ. It is available freely online. I'll share you the link of it. Apart from the software to restore or stimulate the cognitive areas, you can also use Android based game or a paper pencil based game. Vivacity, Ludo, memory games, Sudoku and puzzles. I'll come to the efficacy of this section also. Now coming to the group task and homework assignments. So now when we stimulate when we do the restoration part, when we do the drilling part of the cognition, we parallelly create a group exercises where we uses those component in the group situation, so that they can learn to use it in daily practices. For example, grocery items, kitchen vocabulary, classroom vocabulary, etc. Along with these vocabulary tasks in the group setup, we always ask the patient or a group of patients to generate as many words as possible, or within a particular period of time, and even if not particular period of time. So what could be the vocabulary we use in the kitchen setup? So the next assignment task would be what could be the grocery item that is required, or classroom vocabulary, or any office vocabulary that stimulates the brain in a group setup. Along with that, we do cognitive exercises like go no go task, very famous. And then describing short videos. We always show the videos to the patient and ask to describe the scenes, what the message the film or the video is trying to give, discussing it among the group and discussing the various aspects of it. And the third very interesting game is head, shoulder, knees, toes. We normally play head, shoulder, knees and toes and head. So we keep in a group setup. We always conduct this game by stating, now whenever I say shoulder, you have to touch the shoulder. Whenever I say knees, you touch the knees. Whenever I say touch the head, you touch the head. So head, shoulder, knees, toes, task. We keep on doing it, and it is very engaging and very stimulating when it comes to group brain exercises. And the homework assignment could be the organizing almiras, buying things from the shop. So suppose, for example, suppose there is a problem in the speed of processing. So speed of processing, be it an attentional memory, attentional task. So we give the person a home-based exercises where we tell the patient to organize their almira. And when you are organizing the almira, start a stopwatch and see how much time you are taking in terms of doing a particular task. And gradually you will see in terms of improvement. Like, for example, initially when he or she was organizing the almira, it took around 15 to 20 minutes or 30 minutes. But later, after a practice and maintaining the time limit, it has reduced to 10 minutes and 5 minutes. So you have to keep on giving the exercises so that they get to know so that they can be more functional in their real life situation, not as a task but as a game, as a normally the way we live our life. This is a website, brainhq.com. You can go through it. The first initial picture would be like that. Their memory task is there, attentional task is there, brain speed is there. I'll show you 1 or 2 slides of it. So here, this is an attentional task where 4 dots or ball will appear. After some times, multiple or more dots or balls will appear, and you have to make a tap on those balls which you saw earlier. So these are very interesting games. Short-term and visual working memory task you can see. So in the screen, there are some keys on the screen, and then suddenly, not suddenly, then a blurry picture will come, and then you have to identify where the extra key has come. So it is not the similar picture. It was difficult for me to click in continuity, so just for the understanding, like in first picture, in the first picture, few keys are there, and after sometimes you have to identify any extra key has appeared or not. So that stimulates the visual working memory. So how you can compensate the impairment part? So to compensate, what would be the approach, the principle, the practice and the strategy approach, like bridging group strategy, task planning as per the deficit. So the compensation is like, I believe in, see, compensation is not always when you failed in restoring the functionality. I always tell my students and tell everyone to use the compensatory approaches parallelly to the restorative principles. Because, see, restoration will take time to occur. The impact of restoration will take time to occur. But the compensatory approaches immediately gives the result, can make the person immediately functional in their daily life. So you parallelly, you do your restoration approach, you stimulate the brain, but give the compensatory strategies too, so that it should not be a burden for them. कि मैं इतने time से कर रहा हूँ, but the impact is not coming, because the restoration part will take time to give its impact. Again, the booster session is recommended, be it your restoration or compensatory. So the compensatory task would be based on the deficit area, the functionality, which you can assess. If tools are not available, you can ask the family members, list out what task he is unable to do, and he requires, support in terms of doing that. There's one software, it is also CogSmart. It is freely available online. You can go through it. It helps for compensatory task only. So normally what we do in our setup for compensatory approaches, like suppose if a person is having poor memory or cannot do calculations immediately, has the ability, but may not be very quick in terms of doing it. So sometimes we tell the patient or person to use some compensatory approaches, like you can use calculator, you can use some diary, so that you can list it out rather than putting your motivation down. You can use these approaches to immediately stimulate the person's functionality in real life situation. We do it by role play only. So this is the website, CogSmart, and it will appear like this. It is this manual is for various psychiatric illnesses and also for the brain injuries also. So it is a very good app. I have gone through the app. It is very interesting. For example, for the attentional deficit task, or you cannot, make a list of what do you have to do throughout the day, because most of the time the SMI patients, they don't do productive task at home. Whenever you ask the family members, they're like, पूरे दिन घर में सोया रहता है, he doesn't do anything, he doesn't participate, he doesn't go out. So, and whenever you ask the patient, is like, मुझे कुछ समझ में ही नहीं आता क्या करना है. So in terms of, stimulating and initiating a task, you can make a list of it. It can be based on high priority to medium to low priority. It is from the website only. And there they have given the, hints also, like how you can make it. Be it, if it is meeting someone, doing some exercises, or your daily chores, your activity scheduling of the day. It can be the priority. And then the other household task or the transportation task. So it should be individually tailored depending upon the requirement of the patient. Now comes the problem solving compensatory strategies. It is part of COGS SMART only. So now it follows the same principle what we use in our problem solving technique. Define, brainstorming, evaluate, select, try, and then evaluate. So whatever problem you have, be it interacting with the society, showing your emotions, following your daily activities, maintaining your ideals, whatever problem, be it suppose you have difficulty in, getting up early in the morning, or your difficulty, even if you get up, it is difficulty to initiating your day. So it can be a problem. So now after defining the problem, you have to brainstorm it. Okay, now what you can do it. So we can start with graded task assignments. Like what you like the best, you can start with that. So in that way, problem solving compensatory strategies works very good in SMI population. The third principle is the residual functioning. It mainly focuses on stimulating your brain with brain exercises, aerobic, yoga, meditation. It's just like you just keep on doing what you like the best. Be it reading, be it cycling, be it going out, be it doing exercises. These are all your residual functioning, stimulating the intact area of the brain. So in SMI population, instead you cover the deficit area. Along with covering the deficit area, you also stimulate the intact area of the brain. So my comprehensive kit of neuropsychological rehabilitation could be drill and strategic approach, not drill and practice, because there is no mode of correcting the person. So drill, give the exercises, let the person do the exercise, and keep on correcting it, keep on giving the ways, alternative ways of trying it. Use restoration, compensation, or residual. It is your choice. What I would suggest is use all the principles. Restoration, because it will take little time to show its impact. Compensatory will give you immediate, not very strongly, but not, but a quick fix can be a quick fix. So you can use it, and then residual principle so that it can strengthen the other area of the brain. So order may be anything, bottom up or top down approach. I believe in comprehensive approach. So if you think that the basic bottom attention and speed of processing is intact in the patient, you can start with higher executive function. Or best would be start with give initial few minutes to the attentional task, and then you can shift to the higher executive function task. Group session and homework assignment is must. Never leave the patient without any homework assignment. And then social skill and social cognition is the integral part. In most of the setup, we hardly focus on social cognition. We just focus on the neurocognitive. And most of the time you will hear people saying cognitive retraining de diya, brain stimulate kar diya, and we are doing a lot of exercises to the brain. But this exercises is limited. What requires is the social cognition stimulation, and which is very, the severity is significantly there in SMI population, and we normally ignore it. And again, the booster session. So the recommendation in terms of time and frequency of it can be 5 months. But this month can vary. It can be 3 months also. It can be 5 months also. It can be 1 month also. But depending upon the hours. If you're stimulating 5 to 6 hours a week, then 1 to 2 months is sufficient to see the outcome. Otherwise, if it is standard once in a month, once in a week, so you can go for up to 4 to 5 months of intervention. 3 sessions per week is normally recommended. At least 30 minutes of individual sessions. Why 30 minutes I'm saying? It is evidence-based also. A second factor could be, see, whenever we go for physical exercises, 5 or 10 minutes of exercises or 2 minutes of exercises will not be of any help. So there should be a standard period of time to stimulate it. So at least 30 minutes should be there to stimulate the brain. And 90 minutes session for group intervention. So it can create a good comprehensive kit for you: individual session, homework assignment, and a group session. Your rehabilitation goal should be very clear, because most of the time, and in many cases, I have seen neuropsychological assessment and cognitive training like chali ja raha hai, like for years and years. So what is the purpose of continuing the cognitive retraining? They don't know. So you have to be very specific how you have to do, how much time you have to give. For example, there you want to target the speed of processing first. So you have to be clear in terms of kitna time mujhe dena hai. If can it be for 1 week, can it be for 1 month, and then I'll shift to the other areas of the brain, because if attention is impaired significantly, then you cannot target the higher executive function, because it is the foundation. So the goal should be specific and should be measurable. You have to measure it, whether the outcome is occurring or not, whether the condition or the task that you are working on is achievable or not, relevant or not, relevant to the functionality of the person, and the time period. It should be timely achieved. If it is not, it is difficult to state on timely achieved, but you can set a time frame so that you can keep on revising it. If it is not working, so you have to change your approach also. It is not like blindly you are just going and doing it. यहाँ इसका cognitive retraining चल रहा है. क्यों चल रहा है? I don't know. कब बंद करना है? I don't know. So the goal should be clear. So there are two approaches: manual-based approaches and a computerized approaches. There is no difference in terms of its efficacy. Both are equally effective, be it your manual approach or the cognitive approach. There are other Android-based games also. And believe me, it is equally efficacious. Equivalent to the manual-based approach, equivalent to the computerized-based approach, these games. Now, there's a theory behind this. Because most of the time, what happens in computerized or manual-based training, the participants, they get very tired. Ek hi cheez bar, 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 bar. So it becomes monotonous also, it becomes boring also. Every time the patient is coming, sitting on the screen and doing the exercise, be it speed of processing, response inhibition, or anything. So it is not stimulating for the person. So the commonest reason of dropout is the same pattern. And what happens in Android-based games, based on this theory of self-determination theory, that is very intrinsic in nature, motivating in nature, we do a lot. So I am a fan of Ludo, so I play Ludo a lot. So when you start playing Ludo, those who play games on on mobile phones, they can understand how addictive it is. So if you don't want to follow the screen time, if you don't want to follow the phone, all the games are available manually also. Go to any shop, you can ask for brain exercises booklet or any like for kids, so there are ample brain stimulating exercises. Take that. Ludo is if you don't want to play on phone, you can play manually. You can Sudoku, you can play every day in newspaper. In one corner, Sudoku will be there. You keep on stimulating it. You keep on doing it. So what you can do in your busy OPD, because I know it is very difficult for the medicine practitioner to do the, these neuropsychological assessment and planning the intervention as well and doing the group exercises. I know it is difficult. And in Indian setup, there are very less stations, a very less organization holistically working on rehabilitation. So despite that, we should not feel ourselves handicapped. We can definitely do whatever is possible. So I have prepared this bedside cognitive assessment tool where you don't require any, any equipment. It is based on Stubborn Black for the reference, and the page number is given. You can do the assessment. It takes 10 to 15 minutes, 10 to 12 minutes for the assessment. I have given it the frontal lobe assessment, attentional task. You can do the digit span task, the normal range I have shared. Sustained attention task. Sustained attention, we don't need to cut the alphabet. You can tell the patient whenever I'm going to read out the long series of alphabets. Whenever you hear the word A, B, or any alphabet, you have to tap. So in that way, you can assess the sustained attention. And then again, serial subtraction. If the person is not familiar with the serial subtraction, नहीं calculate करना आता because of the socioeconomic status or the educational level, you can do this backward weekdays count naming, Sunday, Saturday, Friday, Thursday, or the month backward naming, December, November, October. So in this way, you can assess the working memory also, along with that, the sustained attention also. Now, test of language, you can assess the animal naming test within a given period of time. And that this fist palm side test, very common. And that sequencing task you can do. For temporal lobe, you can ask memory task. कल क्या खाया, आज क्या खाया, और कौन कौन मिलने आया. Then about the remote memories, birth ka, when did the person passes the 10th, or any whatever the information you have in your history, you can use it in your remote memory assessment. And again, you can check the comprehension. The comprehension could be very simple also. For example, it can be very direct to understand whether the patient is comprehending or not. Like, is it Thursday today? Yes or no? Or is Narendra Modi the Prime Minister of India? Yes or no? So in that way, you can easily assess the comprehension of the person, or you can look for a very common tool that we use, a 3-stage command task, and then visual memory test. So along with this bedside cognitive assessment, you can give these exercises. Share the apps. If the person is not Android friendly, give them the manuals. They give them, go and take it from any bookstores. You can easily get the Sudoku manual, the jigsaw puzzles, crossword puzzles. So keep on stimulating. Identify the deficit area from the bedside cognitive assessment and give the cognitive exercises to them. Again, sometimes it is not possible for you to do the 10 minutes test also. So very good test is the clock drawing test. It is a comprehensive assessment and it gives a very good, not a good, but a rough picture, but it is very sensitive for the dementia population. But when it comes to SMI population, you can get a good picture of, frontal, parietal, occipital, and temporal lobe functioning. Ask the patient to draw a clock, mentioning time with few instruction. Draw a clock, mention the number, specific numbers in it, and then the time shown. So activation was observed in a bilateral frontal, occipital, and parietal lobe, as well as the supplementary motor areas of precentral gyri, engaging multiple cognitive stimulation by doing just exercises, this vasospatial task. In the single photo emission tomography, high correlation was found in cerebral blood flow with clock drawing test, even in fMRI studies also. And if you don't have the clock drawing test, is very simple to administer. Otherwise, you can also go for your MMSC and HMSC for screening. So this is the test of schizophrenic patient. So clock drawing test. So you can understand this by seeing this picture. Here, the time taken in drawing this picture. I have added one component in this. You have to draw the second hand also, seconds, minutes, hours, and seconds. So the patient in the second picture was unable to draw the second number, and even was unable to draw the, the linings of seconds between the minutes. And the time, see the timing in making this one clock. 4 minutes, almost 5 minutes, and almost 6.5 minutes in the first picture. And frequent turning, and you can put the observation also. And one more thing you can add in your bedside assessment is give 3-4 items like comb, pen, bottle, and tell the person, ask the patient what is this, ask the patient to repeat it, and after this clock drawing test, you ask the patient to recall it. I think it is enough to tap any significant deficit is there or not in chronic patient, and accordingly you can plan your management. So the session structure could be as follows: bottom up approach. You can follow the top down also. Both has a similar efficacy, but the good is from the base to the higher executive functions. So normally you can plan your cognitive retraining. Week 1st to 4, attention and tasks you can give. And then in the 5th week to 7th week, you can give the learning and memory task, and then the language training, and then the executive functioning. So accordingly, you can plan your it is not like today you gave attention, now you do this memory task, now you do language task. Be clear in terms of what output you want to see. Because in most of the setup, I have seen randomly doing it without giving importance to it. ओके आज 2 मिनट का करना था, ठीक है 2 मिनट का कर लिया. ओके आज 15 मिनट करना, आज 15 मिनट. सी द आर इज इम्पॉर्टेंट एंड द स्पेसिफिक एरिया टारगेट जॉब कर रहे हैं, दैट इज इम्पॉर्टेंट. And again, the social cognition part, you don't have to wait for this 13th week to start the social cognition part. You can do it parallelly also. This case, Winnet, these are the patients where we have done the cognitive. It is not a planned because this planned assessments. You can see the timeline also. So we compared the profiles where we have introduced the neuropsychological rehabilitation. So in this patient, a combined approach was used, pre and post assessment done, plus neuropsychological rehabilitation plus psychosocial rehabilitation. So after a combined complete psychosocial rehabilitation package, we were able to see the difference, the adequate areas. In 2022, it was this, and then in 2024, it was this. A significant change. And the second case, out of this 20 sessions, you can see the adequate area. Yes, the adequate area in the first zone and the adequate area after the intervention, after the 20 session. With combined approach only, with combined approach. Neuropsychological rehabilitation and along with psychosocial rehabilitation, because we have a good team in our psychiatric setup, GMCH. So this is another test where pre and post neuropsychological assessment was done without cognitive retraining. So it is not like we intentionally didn't give the retraining to the patient. Sometimes the patient comes for the pharmacological management or for engagement purpose only, but they don't want to be part of neurocognitive assessment or training. They say just for medicine follow-up, they come. So we compared the two assessments, and you can see the significant difference. There is no change. There is no change in the deficit area and the adequate areas, because no intervention was given. And another patient, despite giving psychosocial rehabilitation, despite giving neuropsychological rehabilitation, a combined package, we didn't get any significant improvement. And the reason could be the family factor. Again, the impaired brain that has been given to us. Childhood experiences, traumatic family environment. So there could be multiple factors, but despite giving the comprehensive approach, rehabilitation approach, sometimes we don't get the outcome because of so many reasons. Our neuropsychological rehabilitation kit contains assessment kit and the management kit. My neuropsychological rehabilitation assessment kit carries, number 1, we first do the basic neurocognitive assessment, and then we do the social cognitive assessment, whatever tool is available. And then we do the functional assessment. Any test. It is not like the all test we administer. Sometimes ADL, ideal, sometimes ICF. ICF, I find it very good in terms of tapping the limitations in the real life situation. And then the caregiver burden. And the rehabilitation management kit carries what we actually do in our setup. We take twice a session a week, twice a week session based on restoration principle, where we give the software where the person sits and do the cognitive exercises. 1 week BFT BFT session or MBCR. MBCR is a manual based cognitive retraining. We have created a manual and we give the manual to the person. If that person is not comfortable or due to any reason is not doing the computerized cognitive retraining, we give the manual retraining. And then 1 session per week, group-based cognitive game, restoration-based, where I'll show you some how we do the restoration games and compensatory principles both. And second, Social skill training we do once in a week for around 60 to 90 minutes. There are 2 groups we conduct. So it means it is a 2 session a week, basic group and advanced group. And now what is basic group and advanced group? Basic group, but the basic social skill is required because the social cognition is advanced, is a high cognitive function, high cognitive areas, the executive functions, the attribution, theory of mind, social, emotional. So those who have better social skill scores, we put them on in advanced group where we create we do the group exercises based on the attributional biases. We pick any topic related to the attributional biases. Theory of mind, किसने क्या बोला, किसी ने कुछ बोल दिया, so I started thinking of it. Any topic we pick and then but it is not like any topic randomly. We plan properly. Like this month will be for attributional bias, this month for the theory of mind, this month would be for social and emotional cue perception. And then the homework assignment we always give. And then one session a week, in a month, 1 or twice a session in a month for caregivers. It is very important because in a psychiatric setup, you all will be aware how the family suffers. 1 or 2 member will always be there in the hospital with the patient. So it is very important for us to, psychoeducate them also about their life, that it exists beyond they. So in our setup, Mental Health Institute, what we do, it is a brain function therapy, restorative principle. So this patient is doing the brain exercises. Brain function therapy means restorative exercises. And this is an executive function-based game exercise.
Is there audio also in this clip?
Yes, sir. Sir,
Audio
audio
is not coming.
not audible?
No, audio is not coming to me, at least.
Oh, so it is audio. Audio is there, sir, and I can hear it. So is everyone, if everyone is not hearing it, then I can skip this slide to the next one.
Yeah, we
no,
can't.
no audio input.
No audio.
Okay, then I can shift to the other slide.
Okay.
So this is a caregiver session where we are targeting the doubts about the psychiatric illness the patient is having. Is it also not audible?
Dr. Jyoti, try increase the volume. See if you can increase the volume in the if there is a. Because in PPTs, sometimes audios don't work.
Mm-hmm. No, sir, it is. It should be. Is it now audible?
No.
No, Neet wants to suggest. May I please? I don't know if he wants to suggest something.
Yes, sir.
No, somebody probably is trying to suggest a way to do
ठीक
it.
है विशाल
Yes,
विशाल
all right. Yeah, let's move. Yeah.
We can discuss it later, huh?
Yeah.
Yeah.
Okay, so this is how we conduct the group sessions, apart from the cognitive retraining on the software. So the prognosis, it depends upon many factors. The biological, psychological, and social factors. There are enough literature. Seeing the systematic, if you see the systematic review, but you have to see it very carefully. In most of the studies where the efficacy has been shown, there they used a combined approach. not a single approach. So if you want to have a good outcome, a good prognosis, you have to combine your cognitive retraining and psychological, neuropsychological rehabilitation with other psychosocial rehabilitation plans. Because you have trained the brain, but how will you execute that, outcome that you have found on neurocognitive assessments? So you need environment, to execute it. So these are the evidence-based research. So the obstacle other than the efficacy of rehabilitation is a very common problem that we face is the lack of motivation, which is very difficult. So we have to keep on shifting. Aaj kuch aur kar liya, I mean Android based, then we shifted to software, and then we shifted to phone, and then we shifted to manual based. The core negative belief about cognitive abilities, like they cannot do it, it will be difficult for them. So that these challenges we deal with in the social skill sessions and social cognition sessions. The understimulating ecosystem, the family environment. So despite if the improvement has occurred on the structural level, doesn't mean that it will be on this on the environmental level also. You need to transfer that impact onto the real life situation, and for that you need a supportive environment, and it is not always the scene. The family sometimes not supportive. Even if they are supporting also, the environment is not healthy for the person. So there are a lot of obstacles we face. So when it comes to, the efficacy of cognitive retraining or neuropsychological rehabilitation, it actually lies in the clinical practice. Cognitive retraining harnesses the inherent neuroplastic capacity of the brain, targeting the neural system function across psychiatric condition, thus improving the cognitive function. And it also helps play an important part in the community living. So despite a long history of research and effective and quickly growing evidence base, neuropsychological rehabilitation and practices remain under-recognized among medical specialty, allied health practitioners, healthy policymakers, and the lay public in many settings. So the take-home message from this Thursday Museum would be that we should know the state of cognitive remediation has moved from does it work to what worked best for whom across severe mental illnesses. So start using your brain. Thank you.
Thank you, Jyoti. We'll try to use it as much as we can. Thank you so much.
Alim is thinking, Kash brain hota. Nothing is left. Not even residual.
Yeah. So over to chairpersons.
I wish that video also worked well. That audio didn't work.
Ara ma'am and Sharma.
So any opening remarks from the chairpersons? Then we can go to questions.
Don't you want to answer them first?
Ma'am, we can have opening remarks from you, then we can take question answers from the chat, ma'am.
Oh, okay. No, I mean, I think it was a great presentation, very comprehensive. But, listening to a neuropsych rehab is a challenge by itself. Our cognition has to be very good in order to listen to it. But I only have one simple message, and that is cognitive rehabilitation will have to go hand in hand with PSR, with psychosocial rehab. Please understand that. And for psychosocial rehab, the amount of expertise and training you need is much less than what you need for cognitive rehab. And as soon as you see the patient in the first or second session, this is for the young people here, please start thinking, what is it that this patient really needs? I mean, we know he needs risperidone or clozapine or whatever, but that apart, does he need his cognition to become better? Does he need to study better? Does he need to work better? Does he need to get a job? Should he improve his marital life? Should he improve his personal relationship? These are the questions that must come onto your mind so that you can correspondingly plan interventions for these people. This is not this is not PSR, so I'm not going to talk about it at great length. But just to emphasize and underscore the importance of integrating PSR in very, very simple ways in your clinic, it does not need a bombastic setting at all. And even in cognition, in rural women, they have found, for example, column. I don't know how many of you know columns. Columns are these nice drawings, designs that women in southern India draw outside their house. You know, they draw with rice flour. And these drawings have various levels of complexity. So we encourage these women to draw these columns, you know, because that is cognition for them. That is cognitive training for them. Similarly, like grain sorting, you mix all the dals and the grains together and ask them to sort it out. I mean, these are all very simple measures that, of course, she also gave you a list of all that can be done. But these are simple things that many of our case managers can do, you know, or can advise the women in rural areas. And I mean, this is all I have to say. This is a very interesting topic, and the marriage between cognition, cognitive rehab, and PSR, I think, is very important. And that is why disability becomes more important. You know, disability is again very multifaceted, partly determined by cognition and partly determined by other factors. So I'm really going to stop here because, I'm sure Professor Sharma would want to say something as well. And then we have all these questions that have been asked. So thanks to you all for the opportunity to, you know, voice some of the things that I have to say. Vishal, do I talk about the thing now or later?
Ma'am, after, later. Ma'am.
Okay, fine. Okay, just give me a minute then. Okay.
Yes, ma'am. Yes.
Thank you, Dr. Jyoti. That was,
So your audio is low, sir, somehow.
I'll shout. It was an extremely competent and interesting presentation. Just a couple of things that I would like to emphasize, which you already did. One of them is that gamification always helps in this cognitive work. And as long as we can put in gamification, the motivation to do tasks becomes much more important. The other thing is, apart from gamification producing social rewards, any of these tasks, and we use some of them, the social and tangible rewards really drive performance. And that takes us back to classical behavioral sort of synthesis between behavioral things. We do things when we have a gift or something to acquire which is tangible. We also use any of these techniques and we incorporate them into day-to-day life, but more about that later. I think there'll be a lot of questions for you to answer. Thank you again.
Thank you. Thank you. Jyoti, before we go to the chat box, first, we should have a picture of a person that we are taking up. What a sort of a person comes to you for this sort of rehabilitation? You said a person having bipolar, OCD, schizophrenia, and severe depression. So these are the person who have been treated, and now they have who have been on medications, and there are certain deficits remaining, and then they come to you. So our story starts from here.
No, sir, it is our setup is an inpatient and outpatient, both services we provide. So there are inpatient patients, inpatient services also. So my पास inpatients भी होते हैं, and we see the outpatient patients,
OPD
patients
patients, yes.
also, OPD patients also. So combined
Okay.
patients. Yes.
So suppose OPD patient is there and first time coming to you. So what sort of usual profile is there? What sort of deficits the person is having when you
The
first take it up?
common assessment, common impairment that we see in the profile is the speed of processing. The common problem is speed of processing, along with that the executive functioning, mainly the set shifting and the response inhibition and verbal working memory. So if you see holistically, sir, be it the schizophrenia, be it your OCD, because in mental health institute we see chronic cases only, say severe mental illnesses only.
So Jerry, that is your evaluation. What is the patient's and guardian's complaint? Ki what the patient is not doing and what the patient is doing wrong? What is
Common
the
functional impairment.
Complaints from the patient side and the guardian side.
The chief complaints or the functional impairment that the patient is having?
Chief complaints.
Leave completely normally the see acute basis on acute basis the on OPD basis where the symptoms has been treated and after the symptom remission the patient refers to the rehabilitation section, the mental health institute here, and the remaining we have to sustain the improvement, and most of the time the purpose of consulting to the mental health institute is the rehabilitation and mainly the engagement. Vocational training is the major purpose of coming to the mental health institute, because most of the time the complaint of the family members is like he doesn't do anything, it's ideal despite the improvement, symptom has been settled down, but despite the improvement the patient is not doing anything, he sits at home, he doesn't do household chores and anything. So for engagement purpose wise also the patient has been referred to the section, also to the rehabilitation section.
The patient is not working, he or she is not productive.
Sometimes the
And
productive also. Sometimes the productive also. See, so we also, along with the person who is not productive, coming to a DART and MHI, we are dealing with them also. And those whom we have, reintegrated in the society too. Because there are patients also who are working in the community, who are living in the community, but parallelly they are coming to the OPD, doing their routine follow-up, coming for the exercises. If they are not coming for the is unable to coming for the exercises or brain stimulation, we give them homework assignments. So weekly basis we monitor their routines, also their cognitive deficits or the whatever problem they are facing. So it is not only patient not working, those who are working also, they also consult to the section.
so the deficits are same across the most of the diagnosis. Bipolar patient, schizophrenia patient, the deficits are usually the same or they are very different?
It is grossly, if you see, it is mainly the executive functions and the attentional and speech processing tasks. But yes, in person to person, the profile varies. Be it schizophrenia, within schizophrenia profile also, two schizophrenic patients, cognitive profile is entirely different. One is because of some, educational factors, or the patient is working, or because of the good family environment or the community living. They have their higher executive function, be it response inhibition or working memory or verbal fluency, they are good at it, but the deficit is in the basic speed of processing task. But in other schizophrenic profile, the deficit is also in the speed, the attentional task it is also in the executive functional areas also, be it response inhibition or set shifting or the working memory, mainly the working memory. Commonest profile is the working memory deficit across, be it schizophrenia,
Working.
be it
So
bipolar.
suppose now we take working memory as a example. So how to improve a person's working memory?
So
What should I
working memory,
do? Yeah.
the very important exercise that you can do is the calculation part. Most of the time, if we consider the uh, healthy population, we most of the time for calculation, despite knowing the calculation, it is easy. We use the calculator. We use the easier form. So we should not use that. To stimulate the working memory, we should do it on our own. So mathematical calculation is the simplest working memory task that you can do. Along with that, in daily activities of living, you can do some, like suppose you are going to a shop, you are asking something or you are buying something. So that quick interaction between the shopkeeper and the patient or the self, this also stimulates the working memory, because quickly you have to interpret and you have to reply it back. So working memory in daily functioning also, it is important. And when it comes to restoration or the exercises game, the calculation, mathematical calculation is a good game for stimulating the working memory.
I think Jyoti talked about it in the presentation also, lack of motivation. I said I asked the person to do calculations to go to shop, and the guardian says, "Ki, sir, he does not go. He does not. If I push the 10 times, he goes once." So now, how to take care of motivation there? How to motivate to keep performing the task and improve?
So in these situations where the motivation is not there, there are two approaches. One is, if the person is not motivated at all, you cannot force it. Person has to come to the setup so that we can work upon it. And secondly, if the patient is coming and less motivated, we have to use other psychotherapy modes. For example, to enhance the motivation, we use motivation enhancement therapy. Suddenly we don't start with the intervention, we make the person comfortable with the different sections of the rehabilitation that we have. And then after the patient become comfortable with the environment and the people and the group activity, we then introduce the task to the person. But again, the person who is not motivated, we can try with these alternative approaches. If it is not there, so we cannot force anybody to come and do the, especially after this new Mental Health Care Act.
Okay, so you talked about restoration, compensatory, and residual approach. Approach. So can you briefly summarize, and then we can go to questions in the chat box.
Okay, so there are three basic principles. Restoration is the deficit has occurred and you are restoring the damage by stimulating that area, by creating more and more, electrical energies, synaptic processing of information. Compensatory is like, for compensatory strategies, you don't need to depend upon the deficit area. For example, I have a memory deficit. I cannot remember things. So I cannot dependent upon this deficit area. So what I can do, I can make a diary. I can make a list of it. What I have to do, I have to keep on revising. Ye karna hai mujhe. And for that, I don't need to memorize everything. So compensatory is substituting when you don't want to, restore the functionality. Residual, whatever is intact in your brain, stimulate that. Keep on stimulating. Because every brain area is connected with each other. I hope I'm clear.
Yeah. Thank you. Questions on the chat box now.
Yeah. Shall I take the first question?
Please, sir.
So, Jyoti, thank you for a wonderful presentation. Dr. Sukanto has asked a question to you. Do CR is same for all types of severe mental illness? And how to plan CR in patients of schizophrenia with significant negative symptoms? We have covered a little part, but I think he wants more elaboration on the negative symptoms of schizophrenia.
The cognitive stimulation, see, the brain doesn't know like for what purpose we are using it. So brain has a particular fixed function, be it your frontal lobe, be it your temporal lobe, parietal lobe. So you have to assess it, be it your ADHD, be it any neurotic condition, be it your personality disorder, be it schizophrenia or any disorder. The brain area stimulation, suppose for example you have suppose you have difficulty in interacting with others. This is located in your prefrontal cortex. Now the prefrontal cortex, there are different zones. So by stimulating that interaction zone, so that the brain area doesn't know that this part is associated with by stimulating brain area, it doesn't mean that it is going to have the functional outcome where you start going and interacting with others. It is same for all the zones. You have to identify the deficit area and you have to stimulate the brain accordingly. Because the brain doesn't differentiate कि ये ADHD का है कि ये schizophrenia का है कि ये bipolar का है. And secondly, for negative symptoms, we always recommend for negative symptoms social cognition, social cognition training, social skill training for the negative patient, and we do it. For those who have strong negative symptoms, they normally respond good to the basic social skill training. Severe deficit in social skill, basic social skill, where the art of communicating with others, the art of maintaining eye contact, the art of interacting with others, socializing, that thing we teach in basic social skill group. So for negative symptom, basic social skill training is recommended.
Any experience with Prion diseases or Parkinson plus syndromes?
Parkinsonism, I have not directly worked with Parkinsonism, Alzheimer's and dementia I have worked with, but Parkinsonism, the symptoms comes very late. So in that situation, I always recommend the compensatory approaches. It is of no harm stimulating the restoration part, but compensatory in Parkinsonism is recommended highly.
Thank you.
Okay, role of music, role of pets. I'm combining questions in rehab.
See, anything that you like is good for your brain. Anything that makes you happy is good for your brain. Be it sitting silently, being in yourself, it is stimulating your brain. It is giving you a good neurotransmitter releases, good hormone releases.
So if somebody is happy being quiet, not talking, I'll tell you schizophrenia has negative symptoms. So we allow him to be like that?
So it has to be socially acceptable. If it
So
is
again,
not
that
socially acceptable, that there's a thin line between
anything
normalcy
that
and
makes you
abnormalcy.
happy, you know,
But
society
anything
has
that makes me
no
happy, but limiting
group.
me in my functionality cannot be good. So it is everything stops in when it
Yeah,
comes to functionality.
Yeah.
The role
because
so this role
so
of caregivers
Yes.
in social cognition. Along with that, also explain basic difference for the benefit of audience between what is cognitive rehabilitation, remediation, cognitive enhancement, retraining. So this jargon, is it same or little different?
It is synonymously we use. Training is recommended because it doesn't carry stigma. So retraining is a good term. And second question, sir, what was the first question?
Role of relatives at home, in a home environment for social cognition improvement.
See, when we conduct a group session, social group session, it is in a very closed setup. So the actual situation is the home only and the society only. So when we also train the family members, we take the group sessions, caregiver sessions also, where we ask the person to, sometimes what the family members do, they let the patient be in their zone. ये आएगा ही नहीं तो परेशान ही नहीं करेगा, so he'll be in his zone. So we have to break that wall. We have to tell the family members to engage the patient, be it जैसे मान लो सपोज कोई गेस्ट आ गया and the patient suddenly goes out of that room and अपने रूम में चला गया, he's not interacting with others, and we normally family members allows that. It is not like forcing it, but gradually you have to tell the family members to reintegrate them back into the circle. And gradually it is possible. So they can be the good co-therapists. So I always tell it to everyone. If we have a good co-therapist, our works becomes very easy.
yeah, so having a good support is a good prognostic factor then.
Yes, yes, yes.
Okay, Amrit, have you covered all the questions?
I
Shavit?
think the rest all are not
Tushar?
relevant to the topic, and she's been speaking non-stop for 1.5 hours. It's a very, very tough topic, and
Exactly.
I think we should give her a rest and a pause also. Jyoti has
Yes,
been,
I'm okay. I'm okay.
Shobhit will
answering.
keep on asking questions, so I think
Yeah.
we need to go back to Madam was
Yeah.
supposed to share something interesting.
Yes, Dr.
Let's hear
Thara.
from her also.
Tara ma'am had an announcement.
Thara
Ma'am,
ma'am, announcement.
Yeah, so
Yeah.
something interesting, so we all are waiting.
See,
I
can
don't know whether it's interesting or not, but I think it's important because we had a very dear colleague of ours, Sujit John, who's actually a psychologist, but he was the coordinator for all our research projects. Unfortunately, we lost him at the age of 51 due to cancer colon. I mean, it's been a huge blow for all of us. So in order to, in his memory, we have instituted a SCARF Sujit John Research Fellowship, which will be open to psychiatrists and clinical psychologists below the age of 40 years. The whole idea is to motivate and stimulate young people to get into research. That's the whole idea. We will help in whatever way possible, and we will have a panel comprising of people from other academic bodies also who may act as mentors. I think it's all there on our website. The information is there on our website. If you can disseminate this information, it will be nice, because I truly want research to be taken up by more and more young people, and research on psychosis, not just common mental disorders, depression, and anxiety. Okay.
There are 2 or 3 requests, madam, regarding
Yeah.
this award, where they have requested me to request you to increase the age till 45.
Why?
3 or 4 people have messaged me that can you please request madam to increase the age to 45, because the young are being now 45, less than 45. Alim, you are in the senior category. Don't.
So below 45 is called young now, is it?
Yes, there is a request, madam. 3 people have messaged me to request you to make it 45 if possible. That's a request from a lot of people who are really
that is
working
up to
on
you, ma'am. Yeah.
psychosis. That's a request.
See,
That's come.
this is not carved in stone. I mean, we can certainly, if it's a very good proposal, we can certainly look at it.
Yes,
But we
madam.
also
That's
need
it.
to have some cutoff point.
Yeah, some good people who are doing research in psychosis have just texted me. That's why I'm telling you, madam. On
No,
air,
no,
I'm
no,
telling you.
no, that's what I'm saying. It's not carved in stone. So let them send the proposal across, and we can certainly look at it on a merit basis. You know?
That's more than enough, madam. Thank you so much
Okay.
for considering us.
Thank you, ma'am, for sharing this.
Thank
Thank
you very much.
you.
I wanted to before we end, I just wanted to learn two sharings, Dr. Jyoti. It was a very nice presentation.
Thank
Two
you.
things I learned very interesting from the takeaway for me is just because one part of the brain is sick, we should not just focus on that part of the brain, but also on other parts of the brain which are healthy. So that was a very good learning for me. And second, time is more important. How much time spent on training is more important and doing it correctly for a shorter time. These were the two very valuable lessons I've learned today. So thank you so much.
Thank you, sir.
Thank you. Sharma sir, your comments and if you can put the topic in perspective, what other areas of rehab we have to touch upon now?
I think it was an excellent presentation coming from a person who's doing what he's saying, and that always carries weight. I would like to echo what Dr. Tara said, that the psychosocial part has to be integrated into this. These things are not independent. And I would emphasize that when the family or the caretakers are around, to incorporate them into the program becomes extremely important. And then somewhere along the line, you know, there is, for example, we have a rehab center, we have an extensive sort of a setup. There's a tendency to sort of compartmentalize, okay, this guy goes to rehab, or this guy goes, he's treated in the acute ward and goes away. We are losing that continuity of care. And that the person who comes in with the first episode schizophrenia in the acute ward, he's going to need certain inputs in terms of psychosocial, cognitive, and other rehabilitation. We generally don't look at it like that. We look at rehabilitation as something which is done for basket case, which is not at all true. And so I think an integrated approach should be encouraged, and we should talk more about that, and not just about looking at these things as separated. They all go hand in hand.
Thank you, sir. Thank you. So over to Tufan, sir, and then we end the session.
Thank you very much, Dr. Jyoti, for the nice presentation. It is illuminating. And we have got two maestros in the field, Dr. Tara and Dr. PSB and Sharma, to have their inputs. Personally, this somehow or other has been close to my thought process and practice from the very beginning. And I hold this view that the thought of rehab should come to the mind of the treating psychiatrist or psychotherapist, whoever it is, from the day one. Yes. That is extremely essential. And it's not as essential that we should have a center. In spite of not having a center, and in spite of not having so much, if one can be person specific and can assess the disabilities or defects in the person, or any way we call it, and try to address it. Every individual is totally different from the other person in this aspect. I had been following up a group of street lunatics or whatever it is called, who were wandering lunatics, roaming, and I followed up them for a long time, around 25, 30 years. In some, just getting their home, getting them back to home was more than half of the things done. So many problems could be different. And one has to start from the very beginning without being disheartened. And we were trying to think that it is not rewarding. But even if we rehabilitate one person, and that is itself rewarding, the satisfaction is rewarding satisfaction. And in this planning centers, at times we forget about the people about whose rehabilitation society wants, that are those who are in the street. They don't have a family to collaborate with. No. And I have to think of that. But presentation is very hard, very good, and all this input should be coordinated for the general well-being. In our center, we are going to start a rehab center in a very organized way. We are planning it. I hope that should address everyone. Thank you very much for your inputs, but this is the need of the patients who come to us.
Thank you, sir. Thank you, sir. Amrit, over to you. Please wind up.
Yeah, I'm winding up. Thank you so much, Jyoti. It was wonderful listening to you. It's a tough topic, you know, difficult to comprehend. Forget, practice. So some of the take-home points which Vishal was and Alim had aptly described. So we need to take care of whatever is left. We need to understand that it's a network. We need to understand that if we develop one area, maybe the other areas would get, we don't have to think that this is lost, everything is lost. I think we should understand that this is saved, so we can save a lot of things out of it. And that's what the moment we hear of neuro rehabilitation, we think it's a very, very bad prognosis, poor prognosis, nothing can be done. It's almost like a waste bin type of case. So it's not like that. So thank you for enlightening us. Thank you for making us feel positive about such cases and giving us a direction about how simply we can deal with things. We cannot just complain that we don't have a setup like Alim or Shobit has, or what Dr. Tufan sir does not have. So we can all have the middle path where we can develop our own systems, like Madam was talking about, how simple things can help in cognitive rebuilding, and that's a great take home thing. So thank you to our teachers, Dr. P.S. Vin sir and Madam. So, and thank you, Madam, for accepting the small proposal which many people had put in. Thank you, Tufan sir. Tufan sir is very, very rehabilitation oriented, and he was very happy with the topic. Thank you, Vishal and Alim. And Shobit, you should thank us.
Thank you, sir.
Good night. Have a great weekend.
Good night. Good night. Thank you, sir.
Good
Thank you,
night, sir.
ma'am.
Thank you so much,
Jyoti,
sir.
thank you. Thank you, Jyoti.
Thank you
Well
only
done.
to Alim. Bhagya Alim ka.
Yeah.
Sir,
मेहनत करनी
thank you,
पड़ेगी. You have
sir.
to work hard.
Yes. Chalo, take
Chalo,
care. Bye.
ending the meeting.
Right,
Bye
sir.
bye.
Good night,
Tata.
sir.
Good
Bye,
night.
sir. Bye,
Good
sir.
night, Rajiv sir. Bye.